ready for my phone, guys. It's going to be amazing.
Okay. There's a lot of hair. There's a lot of hair here. I've bought 2 sets of headsets trying to fix this, and my son really appreciates those headsets, both of them.
I'm sure.
Okay, so welcome to Sharp Conversations.
Hi, I'm Suba Aaron. I'm a hospitalist and CEO of Caroline.
We are having conversations around physician mental health and burnout and meeting with experts. And we wanted to talk to you about your experience. I read a little bit about your history, and I thought it was really fascinating, especially like your start with Army medicine.
Hi everyone. I'm Lee Buttz. I'm now the Chief Medical Officer at Tandigm Health. I'm a family physician, and as Janae was mentioning, I've had kind of a varied career of different primary care experiences and working in different environments. I was a primary care doc in independent practice, and then I was working in an employed practice, and then spent some time on the insurance side. And then spent some time in the hospital. So I've seen physician burnout from all different kinds of ways. It's, to be honest, it gets a lot of press right now. I can't remember when I was a doc when they weren't talking about physician burnout, though. It's funny, I didn't hear it so much in the Army.
Like you said, the conversation's been around, and that's something I've noticed too. Like people talk about it a lot. Do you think it's changed at times?
I do think it's changed over time. For instance, when I first was in private practice, EHR stress was not a thing, right? Because we didn't have electronic medical records. I was writing all the time. So the sort of the interference or the interruption of the electronic health record into the exam room was not really an issue. Initially it was more, for physicians in independent practice, it's oftentimes been the administrative burdens of running a practice that only seem to increase over time. So that's a pretty constant for people who are working in that setting, which is driving a lot of the movement of people into employed practice.
I hear a lot of people talking about lack of choice and lack of control over their practice contributing to burnout. And I would imagine that as a specialist, there is more control, at least with certain aspects of what you're able to do and how you do it. So I'd love to hear your perspective as a family medicine physician and the challenges that may be unique from a burnout perspective in that field.
Yeah, that's kind of a double-edged sword. Lack of control is clearly lack of autonomy or lack of control is frequently mentioned as one of the big factors in physician burnouts. But then I think that happens both in an employed and as in an independent practice setting too. So you would think, well, if lack of a control or autonomy is really an issue, then there wouldn't be this push of doctors going into employed relationships, right? Because you would think in an employed relationship, you have even less autonomy. You have a boss who tells you what to do. But we are seeing that shift, more and more people going into or desiring an employed model, because even when you have your own practice, there's a sense of lack of control or autonomy. There's still so many pressures that doctors have to respond to in running a practice that they can feel out of control even when they own the practice, which is sort of a little bit oxymoronic.
Right. So I wanted to ask you too. I noticed you're from Pennsylvania, and my husband did his MPH and his training there before he passed away. And one of the things I remember is they did a lot of work with rural Pennsylvania and the difference in practice, specifically for physicians in Pennsylvania. It was harder to keep physicians in Pennsylvania. So I know, isn't that sort of your expertise,
imperative
right?
of ours that keeping a network intact is something that we spend a lot of time and effort doing. I don't know anywhere where people are saying they're not having problems keeping doctors.
Right.
So I don't know. Pennsylvania, we produce more doctors in Philadelphia than virtually any other metropolitan area. Yet we have trouble maintaining physician staffing. So I think, that's almost a universal problem, especially in primary care. It's really hard. Maybe we just aren't producing enough, but hiring a doctor is virtually, our private practices that are trying to hire a doctor really, really struggle. It's a major problem for them.
So, Lee, how do you
Yeah.
make that happen then? Like, what have you seen work in terms of actually making, I guess, attracting people and keeping them?
I don't know that there's a single answer to that. We feel happy that we have not had a lot of attrition. So just staying even is for us something that we're pretty proud of. That we haven't had a continuous decline in closing practices and that sort of stuff.
Oh, that's interesting.
I think paying attention to the provider experience, designing things around something that's going to make doctors happier, reduce their administrative time, reduce the hours that they have to commit to the documentation aspect particularly. I think there are things that you can do to make doctors happy, and I'd have to think that a happy doctor will be a better salesperson for adding patients to a practice environment. So, I think that focusing more on the provider experience and how we can keep doctors happier is going to ultimately lead to stabilization and growth of the primary care workforce. But it's not an easy thing right now in either independent or employed practice models.
How do we convince decision makers who are responsible for the things that affect the provider's experience that there's an ROI there?
You would think it's pretty easy to put an ROI to something like improving the provider experience because the cost of attracting a doc, the cost of a turnover of a doctor, even the impact on the patient experience. If you have unhappy doctors, you have unhappy patients. From my perspective, the most easily identifiable and fixable thing is how we work with EMRs and designing EMRs. It really exactly, talking to you, Sue, about designing things around how doctors work and not how insurance companies and value-based care companies work. So much of the burnout right now is related to depersonalization of the medical experience, of the documentation and checkboxing and administrative stuff. So it's really not difficult, I don't think, to see the things that are bothering doctors on a day-to-day practice basis. And if they can't document in the office because the systems don't support them, then they end up spending either devaluing the time that they have with the patient because they're typing on their computer and not looking at their patient, or they're spending hours in the evening documenting the stuff that they couldn't do while they were in the office. So I think really designing EMRs around how doctors work and valuing their time is one key thing that we can do to improve how providers, what the provider experience is. Another thing is that doctors sometimes are the last resort for getting things done, but sometimes they're looked at too quickly as a way to get administrative things done. So a lot of things that doctors do are non-administrative are administrative, they're non-clinical. For instance, I was talking to a doctor at a leading academic health institution who was saying that well, in general, we have our administrative assistants do this kind of work. So when the patient comes into my room, I can just do the clinical stuff and review answers, and it's really an efficient use of my time. Obviously that was a pleasant experience. But there's other practices where we don't have enough medical assistants, so the doctor does the work. Now, what kind of sense does that make that the doctor is the one who's taking doing a clearly administrative task, but the medical assistant is too busy or not there, so the doctor does it.
Right.
That talk about working at the bottom of your license, that's not efficient use of doctors' time. And what does it do? It makes them kind of dissatisfied. It's longer time.
Kind of. I like that. It makes them kind of dissatisfied, kind of.
Yeah. So, I think the two things that I could identify, I guess if I could prioritize, improving the EMR and the documentation experience of a doctor, and improving the staffing support for doctors. It can't make sense to have a doctor doing MA work.
Right.
It just can't make sense.
So what is that?
But that's how our system's designed.
What does that mean when you say like improving the EMR experience? Because for people who are watching who aren't super familiar with electronic health records. And for people who, even work for electronic health record companies, nobody agrees on what that really means, like building it around the physician. Yeah. So I'd love to hear your take.
I would say ask Suba how to get the right, literally, that's what she does. She says, this is what the doctors need at the point of care. I'm going to figure out how to pull all that information together so that they can look at everything that's important to them, identify the needs of the patient, and document once in a straightforward and technologically assisted way. That's how you design an EMR. To support the work of the doctor, not to be a billing tool and so, maybe this is why Suba invited me, because I'm giving Caroline a great plug.
That wasn't the intent.
But that's exactly what it does. It designs the EMR or creates an EMR-like experience without around what the doctor does and how they do it, and it leads to great uptake and great satisfaction of the doctor, because they don't feel like they're double documenting or that they're searching for things in different portals or applications to pull data in.
Yeah, that makes sense.
Technology can do so much if we just, design it around what we're trying to improve. And so far, they're not designed around doctor workflows. They're designed around other workflows. And then there's a lot of impediments to changing technology, pulling data together from different sources. So, we have a lot of things developing in silos that's really, I think, stifling the innovation around how we could be designing things better.
EHRs have done a lot. Billing was a big frustration for clinicians. It still is in a different way, but EHRs have taken care of that. When I was in training, I had to really worry about allergies and making sure I was checking all the interactions. I literally don't even have to think about that anymore, beyond making sure the allergies are properly recorded. That's a huge benefit. So I think the question that you asked, Janae, which is really interesting, is why do people perceive it to be so difficult? It just gives me pause because, as you mentioned, Lee, it's possible. Technology has made so many other aspects of our lives so much easier, many that are just as complicated as healthcare. We just haven't seen that shift yet in this industry, which we can. We're not unique. It's totally possible to be able to create ways to make technology fit into our workflow and actually enhance it.
Yeah, that's obviously, there are so many advantages to an EHR, but they haven't lived up to their potential because of the way that they've been designed. Just very simple examples of, someone comes in for a wellness visit, and you may have a template in your EHR, but it's chances are it's like a lot of clicking and scrolling and boxes. It takes a long time to work through a whole physical, right? And then you have an insurance company that wants you to document their specific form for a physical. So in many cases, you have to go completely, all the documentation you entered on one chart, which was probably laborious and time consuming, you have to go over and repeat it in a little bit different way to get the same information into a different form, because that's what the insurer wants. That makes no sense at all, right? But that's... everybody's doing things independently and not trying to figure out how they can make things easier. And, getting to the point of that's what causes the burnout. I just said this. Why can't, I don't have to do this when I go to Walmart or, when I go to the auto repair store. Why do I have to go, and double document things in the EHR? So we're just so far behind the curve in terms of using technology to support the work that we do.
Right. It looks like you have a lot of experience in the payer and the insurance space.
Is there incentive on the payer side to improve the clinician experience?
Is there? That depends. Insurance companies are pretty entrenched in how they do things. I think there's a gradual realization that they are contributors to the physician burnout problem. Clearly. Another thing that comes up regularly is the whole prior authorization process of interfering with the flow of how you're interacting with the patient and getting things done. That many times feels like that feels like it's an impediment and a burden, honestly, it is. And so I think really the movement to value-based care allows, in its most mature form, you don't need utilization management because your providers are doing that. They're taking the accountability for the cost. They're taking the downside. So if they're over ordering MRIs or expensive, Me Too medicines, then they can pay for it. And so I think the movement to value-based care is actually going to hopefully make the burdens of insurance companies less, because they'll rely more on physicians taking that accountability on their own. And so they can gold card you. You don't need to do a prior auth if you're involved in this value-based agreement, because we know sooner, one way or another, it's the right thing to do and it's going to get paid for.
That is really interesting. I had not thought of it that way, that it negates the need for prior auth if you're paying for it out of the money that you have. And I wonder, Lee, how much of the lack of stewardship on the clinician side is related to lack of access to information or lack of access to tools. I was just talking to someone today about how when I order something, I have no idea how much it costs. Right. So it's hard to be a steward of that. If I'm just thinking, I want to order this to both, I don't know how much it costs, or I don't have access to data. So you might have just had that MRI of your head. But if I don't know what the result was and I'm worried that you're having a problem, I need to reorder it.
Yeah. So the really good tools out there to help in value-based care are actually putting that cost information in front of you. I would say if you really think it's necessary, you should order it. The clinical indications for doing stuff is not is more nuanced than just looking at the price or just looking at the test. It's a combination of those two.
For sure. I wonder how many people go into medical school thinking, I'm going to start a business, right? Like you go in, and some people I'm sure know. I can say personally, I did not think about that at all. And I wonder, if there needs to be more integration of just business skills in medicine, particularly for primary care.
Yeah, absolutely. I think that would help. And getting to the burnout issue, it would definitely help. If they had more knowledge or understanding, it might help them make a better decision about what their professional future looks like, whether they want to be an employee or whether they want to own their own business, and just the comfort level. When I got my MBA, I was in private practice, and I said, this is like a business. I got to know more about how to run a business. And that's when I started going to business school, because I said, this is going to be valuable for me just in terms of how I run this business. And, I didn't eventually stay in that model, but the business experience is really critical for reducing stress and improving your ability to make the right decision.
Definitely. All right. Well, I enjoyed this thoroughly, Lee.
Oh, thanks. Thank you, Siva.
Yeah, I feel like I have so many more questions.
Thank you both for having me. It's been a lot of fun.